Happy Friday. What's going on? Happy Friday with our Friday Q&A. I know I'm on Instagram and I got YouTube up, so I know we do these talks every week. But if you have a question or if you need something answered, feel free to use the comment section in either the YouTube or Instagram. Waving back at everybody that waves to me on Instagram. Um, hope all is well. BTF Personal Training, what's going on? Happy Friday. Let's see here. All right, if you got something, fire at me. Good morning, good afternoon, wherever you end up, wherever you're joining us from. Happy Friday. Hope you had a good week. I don't know if you guys saw last talk. We had a great discussion on all kinds of things last week. So hopefully today's just like that. So welcome in. This is your open forum, so fire away. Again, last week we talked a little bit about the overhead squat and how we use that. I know a lot of the questions that we get are about kind of assessment based. So what to do with somebody who's got X, Y, and Z. So what to do with somebody who's got feet flat and their feet turn out or something along those lines. We kind of dive into the assessment side of things. We also talked a little bit about programming, when to put exercises or when to put different phases through. I didn't get any emails last week with additional questions, so I'm leaving this completely up to you. Feel free to write some stuff in here. Let me scroll through here and see what's up. Great question. The solution to fix internal rotation of the knees, if you have somebody performing that squat or that overhead squat. So what I'm going to say though is that internal rotation, what we're seeing with knees bow in, we'll use that as our kind of sign or our measure there. So when knees bow in, you're getting a little bit of a combo of two things. You're getting femoral internal rotation, and relative to the femur, you're getting some tibial external rotation. So that would be our knees bow in. Now, to figure out where that's coming from, we need to do that overhead squat with modification. So it could be coming from something at the ankle, or it could be coming from something at the hip. So we have to figure out how we can differentiate where that's coming from. So what we're going to do is we're going to elevate the heels and have that person squat again. Now, as an assessment side of things, if their heels are elevated, what we've done is we've given them additional range of motion at that ankle. So we've given them essentially artificial range, and we're going to reassess or reevaluate and say, okay, did their knees still bow in, or did that kind of fix the problem, right? So there's two options or two directions that we can take here, right? So if that corrected the knee bow in, then we know that that knee bow in is coming from some sort of restriction at the ankle. So our intervention is going to be releasing your calf muscle complex, releasing your fibularis, maybe doing a mobilization of the ankle joint, doing some calf stretching and some tibialis anterior, tibialis posterior activation. But if we elevate the heels and the knee bow in is still there, or even if the knee bow in is kind of like wobbling a little bit, then we can say, okay, it's coming from something at the hip, right? It's coming from something at the lumbopelvic hip complex. So it's going to be my internal rotators, like my adductors, maybe my TFL is involved. So that one's going to be a little bit different of a treatment plan. We're going to go release adductors, release TFL, maybe do a hip mobilization, do some stretches for that anterior adductor TFL complex, and then go into some glute activation. So that one is it's a great question. The knee bow in sign, how can I make that better? How can I kind of correct that when somebody's squatting or doing whatever it is that they're doing? But we really have to get a little bit more specific to where that problem is coming from. So great question. You just have to get a little bit more info from that person and go from there. Right? Great question. Yep. Cool. What else you guys got? Throw some more stuff out there. That was a good start. And obviously, everybody that waved to me, waving back. I know we got a couple people in here that are in here all the time, so welcome back in. You get to put up with me again for 30 minutes. Cool. And that kind of knee bow in side of things, and really when we look at that overhead squat, there are a few different signs that you see when somebody's squatting that you may need a few more or a little bit deeper detail in. So you have things like knee bow in, you have things like anterior pelvic tilt that could come from either lumbopelvic hip or upper body dysfunction. So that would be something that we'd have to kind of go through, right, and figure out where it's really coming from. Knee bow out would be in that category as well. So it could be coming from something at the lumbopelvic hip, or it could be coming from something at the ankle. Excessive forward lean is another tricky one. Excessive forward lean could come from lumbopelvic hip, but most often comes from lower extremity dysfunction, so some sort of restriction in that ankle. So you have some of those different dysfunctions there that may come from two different segments, which is why that overhead squat with modification becomes really, really important. So, Patrick on YouTube here. Again, thanks for always chiming in. Have clients or patients saying they feel during a clamshell they feel that bottom leg as well. You might need a little bit of an adjustment there. Maybe move the knees closer to their chest or further away. Maybe pull the feet back or forward just a little bit. Again, I know it's tough to kind of tell you what's going on there in this virtual format, but try a couple different positions, right? But also remember that as they do that clamshell and they kind of open up on that top leg, there is tension on that bottom leg as well, right? And keeping that femur, keeping that leg on the ground is going to require a little bit of activity there from that downside or that bottom side glute. So feeling that bottom leg or feeling that bottom glute working is not always a bad thing. That might be okay. But when you go to the point of pain, then maybe there's something else. And maybe that's just not an exercise that that person should be doing. Maybe we can kind of regress it or change it up a little bit. Instead of clamshells, maybe try straight leg lifts. Maybe that would be better, feel more comfortable for them. So you can kind of play around with stuff like that. But like I said, you're still going to feel that bottom leg. You might still feel that bottom leg working. So maybe that's not a bad thing at all. Right. But like I said, first try kind of different positioning, then go and say, okay, let's change this movement up a little bit. What's the best way to address frozen shoulder? Don't go have that person go to a physical therapist, orthopedic, chiropractor potentially. It's just a recipe for disaster for personal trainers and even some manual therapists to go and try and address frozen shoulder. Don't address the diagnosis. Again, we start talking about don't worry about the diagnosis, address the dysfunction. But with frozen shoulder, it's going to be a little tough. You can try some release techniques, trying some. You just might not have the best outcomes there if that's not within your scope of practice. So refer out. Your client or patient will thank you for it. Let's see. Amanda J. Sorry, if it was just one knee bow in, would it be more likely a prior injury potentially? So there's a lot of things that we see when it comes to your overhead squat assessment or just assessment in general. And oftentimes we see asymmetries, right? It's not uncommon for one person to have one leg that bows in and one doesn't, or one hip that kind of moves off to one side, or one asymmetrical hip shift. So that's something that we also can address, right? We have to take a step back here and say, okay, if I see somebody doing a squat and I see kind of an asymmetry somewhere where one leg looks like it's going out or in or whatever, and the other one doesn't, take a step back, go into that posterior view of that person doing the squat and see if it is an asymmetrical weight shift, because that gives us another sign that we can address. That asymmetrical weight shift is very common. There's a lot of people that have an asymmetrical weight shift in their squat. In doing so, that tells you a little bit of what's going on from one side to the other. There are situations or circumstances where you have an overactive group of muscles on one side and a group of muscles on the other side that are not overactive or that are not, contributing to that dysfunction. So you may have to just address one side. I'll give you the example there of, I'll kind of give you two examples. I'll do the overhead squat with that asymmetrical weight shift, right? When you see that asymmetrical weight shift, let's say it's coming from lumbo-pelvic hips. So you elevated the heels, put the hands on the hips, they squat again, and they still have that asymmetrical weight shift, right? Now, if they shift off to the right, it tells us that we have some overactive muscles on the left side, like bicep fem, posterior fiber, adductor magnus, and piriformis, and underactive glute on the right side, right? The side of the shift. So we're going to do our release techniques just on one side, on that left side, the overactive side. And we're going to do our activations just on that right side, the underactive glute side, right? And that's going to be our treatment or our intervention for that asymmetrical weight shift. So that one gets a little tricky. I know sometimes those asymmetries, like especially that asymmetrical weight shift, people go, oh, I don't know what's going on there. Like, oh, that's too much, right? But we do break it down. There's actually a course on the website or a video on the website that kind of breaks that down for you and makes it a little simple. So I think that's another big mistake. The big mistake there is, oh, okay, so I got some overactive muscles. Let me release everything, right? And what you've done there is you've made both sides more mobile, but still asymmetrical. So when you see asymmetries in a squat or in an assessment, make sure you treat that more restricted side, right? And treat that side only until it's somewhat even with the other side. So I know it's a little bit there. I tried to answer actually two questions there in one, so that one-sided whatever, knee bow in, knee bow out, whatever it might be, or one arm forward and one arm, able to stay up, right? Treat that less mobile side, right? And that kind of goes the same with that hip shift. So Faith Fitness HTX, that hip shift, we're going to break that down and see where it's really coming from, and hopefully can get to the bottom of it and find those overactive muscles on the one side, underactive muscles on the other, and your treatment or intervention becomes pretty easy from there. All right, let's see what else you guys got. Pain in the low back area, go see someone. Go see a physio, go see a chiro, go see an orthopedic. I can't really give you much more than that, right? So I'm sorry. And BTF, personal training, best way to address a client with frozen shoulder is to refer out, have them go see somebody. So those two questions, I know it's almost like a little mini cop out, but I can't give advice on back pain via Instagram or YouTube, right? So I can't say, oh, you're having pain, do this, because I don't really know where that pain's coming from. And there needs to be a little bit further or more detailed assessment. So they need to go see someone. Let's see what else. Happy Friday. What's up? Yeah. What's the difference between physical therapists and a chiropractor? So schooling's different, right? Obviously, schooling's a little bit different between the two. Physical therapists have a little bit broader scope of practice. And really, if you're asking for what you like for you, you have to find what you like and what you think would be most appropriate for your kind of career path / direction that you want to go. I think physical therapy is kind of a good kind of profession to pick. You have this, like I said, a broad scope of practice. You can work with a lot of different spectrums of things. Chiropractic certainly a great profession as well, but that's, so I think sometimes you get a little bit tougher kind of if you're not going to kind of open up your own practice, you get kind of a smaller uh, job opportunity side of things. So just you have to figure out the difference, what you want to do, what you think is the best approach. Like I said, you have to find what you're obviously passionate about and kind of go after that. But both of them great. They can both kind of treat various and address various issues and conditions and problems. But like I said, that physical therapist tends to have a little bit larger scope of practice, a little bit more schooling with that. But both are great, right? So and both have certainly have their place. Um, Physical therapists and chiros are starting to kind of integrate into more of like a kind of a well-rounded approach. So the chiropractors that just kind of like adjust and send you on your way, I think are kind of slowly just starting to, I don't know, let me say phase out, but not, I don't mean that in a bad way. But they're starting to kind of integrate more of the corrective exercise along with mobilization, right? So they're starting to kind of bring all of these fields together. Same with physical therapists. The physical therapists are now starting to kind of integrate a little bit more of the manual therapy plus physical activity, like the weight training side of things, and seeing the benefits of how that optimizes outcomes. So that's all in there as well. So I think both of those fields are kind of heading in the right direction. And we're starting to see even more collaboration between physical therapists, chiropractors, manual therapists, massage therapists, personal trainers. Like they're slowly starting to blend together and collaborate and work with each other. So I think that's a great thing for the industry, because really all it's going to do is going to optimize outcomes, get people moving better, feeling better, which is the at the end of the day the name of the game, right? Cool. Let's see what else we got here. Anything else? There we go. PNF stretching prior to plyometrics, this would be counterproductive, probably. Heather, yeah, and it depends on what they did and what they stretched. Um, Probably, I'm just guessing, but one of the more common stretches that coaches do is hamstring stretches, especially using a PNF style stretch where you just pull that leg up as high as you can. Then they have their client or patient push into them and relax, and they get a little bit more range of motion, and they're just lengthening muscles just to lengthen. Unless they did some sort of assessment that identified that that muscle needed to be stretched, they probably made that worse, or made that potential for force output worse, right? So often what we find in a lot of athletes, especially if you're dealing with uh, gymnasts in general, because I know, Heather, that's kind of what you deal with. Um, Most of them probably have some sort of compensation somewhere. So most of them probably have an anterior pelvic tilt, or just they're lengthened, right? So their hamstrings are already kind of lengthened. Um, and then you just take that muscle and lengthen it more, force output will go down. Yeah, it's based on that length tension curve, right? A lengthened muscle, it's not a strong muscle. So that becomes a problem. If you're just arbitrarily stretching to stretch, that's not really a great solution. But if that coach or whatever did an assessment and identified some movement compensation, then they decided that yes, this muscle, whatever muscle they were stretching, needed to be lengthened, then maybe that's a good thing. And then maybe they optimized their force or power output. So it really just depends on what they did, what the assessment said, and go from there. And I think that brings obviously a really important point, is that you don't want to just stretch people to stretch people, right? There needs to be some sort of assessment that goes in that identifies shortened muscles, right? So don't stretch hamstrings. How about that? How about I sum it up like that? Stay away from the darn hamstrings. Let's see what else I got. Let's see. So the side weight is more on is the underactive. So I'm thinking you're talking about that asymmetrical weight shift. So when that person squats and let's say they shift off to the right, it is the side that they're shifting to is the underactive glute side. Now that is only if it's coming from lumbopelvic hip complex, right? So we have to elevate the heels and put the hands on the hips and have them do that squat again. If that is the case, their heels are elevated, hands are on the hips, and they still squat and still see that little bit of a shift. It's that right side. Let's say they shift to the right. It's the right side glute that is underactive, right? Because the left side, bicep fem, posterior fiber adductor magnus, and piriformis, they have that little bit of a kind of a lateral pull to them. So they're going to be kind of pulling that femur, pulling that leg off to the side. And by pulling that leg off to the side, your body's got to counter by shifting to that right, right? So hopefully that kind of makes sense. And you guys can kind of visualize that. Marilla, what's up, man? Hope all is well out by you. I know it's been a while, but and Cabby, happy Friday, bud. I see you jumped on. What else you guys got? Ask away. Any questions? I'm waving back at everybody. Let's see. Best way to release overactive upper traps, and then favorite exercise to activate mid-lower traps to coach them into setting the scapula. So when you start dealing with upper body dysfunction, it's usually not just upper trap that's overactive. You usually have kind of a combo there of levator scapula, rhomboid, and pec minor and upper trap kind of working as like these overactive muscles pulling that scapula into a terrible bad position. So what I tend to do, or what I tend to focus on, is levator and rhomboids. And then you can kind of throw upper trap in there as well. But I take a ball, tennis ball, softball, trigger point release ball, whatever you have, right, up against the wall. You're going to put that ball kind of facing away from the wall. You're going to put that ball right on that superior angle of the scapula. That's going to hit levator. From there, you can turn to like a 45-degree angle and start to get into some upper trap. Right? And then from there, we can let that ball drop back down in between those shoulder blades and hit rhomboid. Right? Maybe do it both sides, right? Depending on what you found in your assessment. And that's a nice little flow, right? So that ball sits there on that right above that superior angle of the scapula, so you can hit levator, transition to that nice kind of 45-degree angle so you can hit upper trap, and then spin back around, let the ball fall down in between your shoulder blades and hit rhomboid. So there's that nice little flow from one muscle to the next to the next. From there, I tend not to stretch stuff, right? So what I found over the years of having somebody try and stretch their upper traps or stretch levators, it ends up flaring them right back up, right? For whatever reason, there's a whole bunch of stuff in there that gets mad when you start yanking on it. So I tend not to stretch it. I'll do the static release, and then I'll do the dynamic release with those muscles, and I'll use like my head for levator and upper trap, so I get a little bit of motion in there. And I'll use my arms going into protraction, retraction for rhomboids. So I'll do my static release, do my dynamic release, and then I'll start going into that mid-low trap activation. So I also add serratus in there as well, because serratus is going to set that scapula in the right position also. So I have your wall wise, right, as an option. So my wall wise or floor wise, depending on that ability of that person. I have my IT wise, so I can do it standing, I can do it laying on the floor, I can do it off of a bench or off of a massage table. So I'll throw those in there as my mid-low trap plus serratus activation stuff. And there's a whole bunch of progressions and regressions there. So you also have like wall angels. And again, it's going to depend upon that capacity or that ability of the client or patient that you're working with. But those wall angels are great for that serratus as well. Like I said, those ITYs are great. You can load them up, or you can do standing up against the cable machine, right? And using that cable machine to help get that like depression for low trap. So that's kind of where I would go with that. So hopefully that's helpful. Darren, 1985. Let's see, where else am I headed? Back pain, go see someone. I know if you said you're getting out of bed and you're in back pain, it could be a whole bunch of stuff, but I would recommend going to see somebody. Go talk to a physio or a chiro or somebody along those lines. See what they can find. Again, it'll probably require some sort of assessment. Scroll down, waving back at everybody. Arm getting numb when you're tracking the scapula, go see somebody. Yeah, so you might have some sort of impingement there. Um, but you might need some manual therapy, might need some work on an adjustment, something along those lines. So I would definitely say go to a physio that you trust, go to a chiro that you trust, go to an orthopedic that you trust, and see what they can do. Again, they may need to do an assessment, they might need to do some testing stuff on you, and go from there. Right? I can't really tell you much more than that via Instagram, so I'm sorry, or YouTube or whatever. Anterior pelvic tilt help. I'll finish with this one because we see this a lot. So anterior pelvic tilt, we see it a lot in all kinds of clients, from people who sit at a desk all day long to even your higher level athletes, right? That anterior pelvic tilt, what's going on there is that we have kind of a combo as well of a hip flexor complex overactivity pulling the front side of the pelvis down. And then we also have that latissimus dorsi, because that connects to that pelvis from the backside, pulling that posterior iliac crest up, right? So when you're dealing with the anterior pelvic tilt in the overhead squat, do the overhead squat with hands on the hips and see if that improves, right? Because then we can really differentiate where it's coming from, whether it's coming from the lats pulling the pelvis up, or if it truly is something at hip flexors, or something at that lumbopelvic hip complex. So with what we're doing there is, okay, let's say it's coming from lumbopelvic hip, it's release TFL, release rec fem, release, let's say your anterior adductors, do a mobilization of the hip joint, right? And then do maybe a TFL stretch or anterior adductor stretch, and then activate glutes, right? It's glute, glute, glute all day long, along with some TVA, right? That's going to help kind of reposition that pelvis in a neutral position. So that would be if hands on the hips, that anterior pelvic tilt is still there, right? If you find that that anterior pelvic tilt is coming from upper body, so you had hands over your head, right? And you did that squat and you saw an anterior pelvic tilt, and then you put um, your hands on your hips and that anterior pelvic tilt went away, then you know it's coming from upper body. So then it's easier. It's just release lats, mobilize the shoulder joint, right? Do a child's pose stretch, activate external rotators of shoulder like infraspinatus and teres minor, and then reassess, and you're good to go, right? So anterior pelvic tilt, I know it's a tricky one, or I know it's a common one rather, but we have to find out where it's coming from, what it's coming from, and address accordingly. So that's the very important piece of do your assessment, do your intervention, and then reassess and see if your intervention made it better or improved it or fixed it or whatever you want to say, right? If it optimized outcome, that's kind of our goal. And if you didn't, you have to go back to the drawing board and say, okay, what did I miss? What did I do wrong? Were the exercises not performed optimally, right? And go from there. Cool. Happy Friday. Guys, go have a good one. Go do great things this week. Hope everybody has a good weekend, and I'll see you guys next Friday, same time. So next Friday, we'll call it 12 o'clock Eastern Standard Time, 11 o'clock Central Standard Time. Go do great things. I'll see you guys later.